Alhamdulillah, wassalamu ala asyrafil anbiya'i wal mursalin. Okay, so this session is a long case session kan? Okay,
Yes.
and I've been informed you guys got 2 cases to present. Am I right?
Yes.
Yes.
Okay, so uh, I'm not sure about your exam, but your seniors, the 5th year's exam, end of block exam is coming, I think, next week. And they are having a modified long case rather than a like traditional long case. When will be your exam?
Early of bulan
October,
9.
September.
9 September, yes.
Then I presume, looking at the trend of COVID nowadays, especially with the development of new cluster yesterday, Najib's new cluster, I believe we are having another MCO soon. Then probably you guys akan ada modified long case lah. But for today, we continue like a usual long case punya presentation. And then have you guys got like a briefing on how modified long case will be conducted ke benda macam tu ada ke?
Not yet,
Not
Doctor.
yet.
No, no,
Yet. Okay, I think it's a bit too soon lah. We wait until September then only we discuss about your exam. Anyway, so let's not waste our time. So kita continue dengan the first presentation. Who's going to present?
Me, Doctor.
Okay, so Aisyah Malin. So you're going to present a case you've clocked in the past.
Yes.
Is it pediatric case or
No, me from case right up.
from case right out? So it's pediatric case lah.
Yes.
Oh, okay lah, okay lah. So okay lah. So we focusing on the presentation. So the content and the technique lah. Mainly the content and the technique. So everyone are expected to listen carefully on how Aisha's going to present and give feedback afterwards. Okay. And you guys will be scored lah for this session for your final exam, I think. End of block exam. Okay. Anyway, so boleh start lah, Aisha.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Okay, my name is Nia Aisyah Malin and today I will be presented a case. Okay, this case, MFH, an 8 years old Malay boy was referred to HTA emergency department with the complaint of fever for 9 days, neck swelling for 4 days, and abdominal distension for 1 day duration. Okay, this history was taken from the father. The patient was apparently well until he developed fever for 9 days prior to the admission. It was intermittent in nature, which usually strike up at the night. The father reported that his son was warm to touch and the highest temperature recorded at home was 38 degrees Celsius. It was not associated with chill and rigor. The fever was temporarily relieved by syrup paracetamol for a few hours only. However, it then occurred again at night. The fever also associated with runny nose with clear foul-smelling discharge. Okay. The father also noticed that his son started to develop neck swelling on the day 6 of illness. It was initially small and later the father noticed that it started to progressively increase in size. The swelling was hard in consistency. It was on the right side of the neck with the size of 2 finger breadth. It was associated with redness around the area of swelling and pain upon touching. However, it was non-itchy and there was no discharge around the area. The swelling did not restrict the neck movement, otherwise there was no swelling around the armpit or groin area. The patient also developed abdominal distension that occurred around the right upper part of abdomen. The father described that the distension was hard in consistency, it was pain upon touching, and it occurred suddenly. Worrying about the condition, the father brought his son to Clinic Al-Razi. and he was told that his son had liver enlargement. Then the child was admitted to emergency department of Pekan Hospital first, and then was transferred to HTA for further management. Upon further questioning, the patient also developed swelling around both of his eyes on the day 4 of illness. There was no variation whether in the morning or at night. It occurred throughout the day. There was no history of swelling in other body parts such as limb swelling. Otherwise, there was no history of redness of the eyes. There was no history of purulent discharge of the eyes or eyelid swelling. Plus, he also experienced sore throat. It causes him discomfort during eating. So, the sore throat caused the patient to have reduced oral intake. However, the patient still can tolerate fluid and he was still active. The father also noticed that the patient developed rash on the day 4 of illness and the first day of admission. It was multiple around the neck area and trunk. It was red in color, raised, non-itchy, and not associated with any discharge or disclamation. The father claimed that the rash developed especially after the consumption of antibiotic. Besides, there was history of swimming at the Cherating swimming pools in last month. The father denied any sick members in the family or any contact with sick people. He is not from dengue-prone area, and there was no recent history of fogging. Father denied any color changes in the urine, changes in the volume or urination, and pain upon urination. Otherwise, there was no history of dry, cracked lips or lesion in the tongue. There was no disclamation around the fingers or toes. There was also no redness of the palm or soles of the foot. There was no history of malignancy such as lymphoma or leukemia running in the family. The father also denied any weight loss or drenching night sweat. Okay, for systemic review, generally there was no loss of weight, but there was loss of appetite. For gastrointestinal system, they are normal, which is no constipation, hematemesis, melena, jaundice, flatulence, or bowel incontinence. For cardiovascular system, also normal. There was no cyanosis, orthopnea, paroxysmal nocturnal dyspnea, reduced effort tolerance, or ankle edema. For respiratory system, there was no hemoptysis or night sweats. For genitourinary system, there was no frothy urine, hematuria, urinary agency, frequency, intimacy, incontinence, and dysuria. For hematological system, there was no bleeding tendency such as gum bleeding, epistaxis, and bruises. There was also no pallor. There were no symptoms of anemia such as palpitation, reduced effort tolerance, and giddiness. For neurological system, there was no weakness, loss of consciousness, headache, impaired hearing and vision, or episode of convulsion. Okay. For past medical and surgical history, this was first hospitalization. Otherwise, there was no known medical illness or significant surgical history. For drug history, the patient was only given syrup paracetamol and antibiotic from the clinic for the fever. Allergic history, there was no known drug or food allergy in this patient. For immunization history, according to the father, his immunization is up to the schedule in accordance to the vaccination schedule by Ministry of Health. There was no history of missed vaccination or added vaccination apart from the schedule. No post-immunization complications such as rash or fever. Okay, for birth history, antenatally it was uneventful. Intrapartum, the child was born term at 40 weeks in Hospital Pekan via spontaneous vaginal delivery. His birth weight was about 3.5 kilogram. Postnatally, the child had neonatal jaundice but required no admission. Otherwise, there was no other postnatal complication. For growth and developmental history, according to the father, he is growing well and appropriate for his age. He is currently studying in Sekolah Rendah Seri Biram Pekan. He is in the second class and placed second for his current examination. He can write, read, and do simple calculation. His favorite subject is English. He also participates in sports activity. He is mixing well with his friends and there is no problem at school. For nutritional history, the father was unsure about the breastfeeding history. The patient started weaning at 6 months old, where soft diet such as porridge was introduced. Currently, the patient is on normal adult diet. He eats 1 to 2 heavy meals per day, consisting of rice, some protein like chicken. He disliked fruits and vegetables. For family history, both of his mother and father are still alive at 37 years old and 40 years old, respectively. There was no history of consanguineous marriage. Both of them have no known medical illness. He is the eldest child with 2 younger brothers and 1 younger sister. All of them are currently healthy with no similar presentation. For social history, he lived in Kampung Taman Tengah with both of his parents and siblings in a single terrace house. Their housing areas have adequate clean water supply and electricity. His father works as a technician at the RB Highcom, while his mother is a secondary school teacher, with total household income about 7,000 ringgit per month. His father is an active smoker but claimed to be smoking outside the house. Otherwise, there are not both parents are not alcohol drinker or involved in any high risk behavior. The nearest clinic is Klinik Kesihatan Bandar Pekan. Okay, that is for the history. Doctor.
Kenapa?
Should I proceed with the physical
Summary.
examination? Oh, summary.
Sepatutnya actually your presentation you should limit sekejap, I tak sure sangat. Your long case kan, presentation, your presentation should be berapa minutes ah?
1 hour pula, 30 minutes with the examiner.
Examiner kan? Okay. Try because it's already past 10 minutes. Actually try to present in the most is like 15 minutes the most. So you can have another 15 minutes with the examiner lah for Q&A. For Viva. Jika boleh I give you another like 1 or 2 minutes.
Huh?
You boleh present lah dia punya physical examination.
For
2
physical
minutes
for physical examination, generally patient was conscious, alert, not in pain and not in respiratory distress. He was able to lie in supine position without having difficulties. There was granula attached at the left and right dorsum of his hand with no active infusion. On peripheral examination, there was no clubbing, palmar erythema and peripheral cyanosis. His peripheries were warm. The capillary refill time was less than 2 seconds. There was no bruise present. BCG scar was noted on the left side of his shoulder. Conjunctival pallor was noted. However, the patient was not jaundiced or cyanosed. The periorbital edema was noted on both sides of the eyes. On mouth examination, there were exudative tonsils noted bilaterally. On neck examination, there were anterior cervical lymphadenopathy noted on both right and left side of the neck, measuring about 2 times 1 and 1 times 1 centimeter. It was hard inconsistency with rounded border. It was not mobile and not attached to the skin. There was no skin discoloration, tenderness, warmness, and discharge around the area. There was no pedal edema. For anthropometric measurement, the weight is 20.1 kilogram. Height is 1 to 8 centimeter. For vital sign, he is normotensive with 100 for pulse rate, 100 beats per minute, good volume and regular rhythm. For respiratory rate, 28 breath per minute. Temperature, he is febrile currently. Okay, for abdominal examination on inspection, abdomen was slightly distended on the right hypochondrium. The umbilicus was inverted and centrally located. The abdomen was moving symmetrically with respiration. Otherwise, there were no scratch marks, dilated superficial veins, hyperpigmented or hypopigmented of the skin, no scar noted. There was multiple small-sized maculopapular rash noted on the abdomen. It was blanching and no peeling of the skin noted. On palpation, abdomen was soft and non-tender. there was hepatomegaly noted 4 cm below the costal margin. The liver span was 14 cm. The liver surface was smooth with normal consistency. Kidneys were not palatable. Percussion revealed no ascites. However, the trough space was dull, indicating mild splenomegaly. Normal bowel sounds was heard. For respiratory and cardiovascular examination, they are all normal except that there are multiple small size macular rash noted on the anterior and posterior chest. Okay, for summary, this boy at MFH, an 8 years old Malay boy, presented with history of fever for 9 days, neck swelling for 4 days, and abdominal distension for 1 day duration. It was associated with sore throat with reduced oral intake, periorbital edema, and multiple rashes on the neck and trunk that occurred after the antibiotic consumption. On examination, there were conjunctival pallor, periorbital edema, bilateral exudative tonsil, bilateral anterior cervical lymphadenopathy, and maculopapular rash on the neck and trunk. And also abdomen. On abdominal examination, there was hepatomegaly 4 cm below the costal margin and splenomegaly evidenced by dullness on the trough space.
Okay, is that all?
Yes.
Okay, what is your working diagnosis? Sorry, how old is the child again? How old is the child?
8 years old.
8 years old, okay.
My
So, what's your differential? Your working diagnosis and your differential diagnosis?
my provisional diagnosis is infectious mononucleosis. For the differential diagnosis, it is the first one is lymphoma, acute leukemia, PSGN, post-streptococcal glomerulonephritis, also Kawasaki disease.
Okay, what makes you think? What makes you say this is a glandular disease, glandular fever, or infectious mononucleosis?
Because the patient has fever, neck swelling, abdominal distension, sore throat with reduced oral intake, presence of maculopapular rash over the body after antibiotic consumption, presence of periorbital edema, which can occur in infectious mononucleosis. Also, on physical examination, there is presence of anterior cervical lymphadenopathy, exudative tonsil, indicating probably tonsillitis, and there was hepatosplenomegaly in this patient.
Okay, what is the cause for infective mononucleosis?
Epstein-Barr virus.
BV, and then what sort of antibiotic cause rashes in ABV infection?
Sorry.
What kind of antibiotic that cause rashes in ABV infection?
Mm,
You've mentioned the rashes come after antibiotics, and what kind of antibiotics?
uh, from the history, the father didn't mention what is the name of antibiotic.
But what do you think the antibiotic is?
Mm,
Okay, it's penicillin group lah. Okay,
oh.
penicillin group. Okay,
Cephalosporin apa?
uh-huh.
Cephalosporin?
Cephalosporin, actually theoretically it can, but classically it's penicillin group. Okay, classically it's penicillin group lah. Tapi of course, the two groups have similar mechanism. Okay, what's your differential again?
Lymphoma.
Okay, what makes you think this is lymphoma, or what against it?
Uh, for lymphoma, because there is fever, neck swelling, abdominal distension, and for physical examination, there was cervical lymphadenopathy, hepatosplenomegaly, which this can occur in lymphoma. However, there is the points against is there is presence of periorbital edema and rash, and also sore throat, which is not commonly occur in lymphoma.
Okay,
There
how
is
about the accuracy?
sorry.
How about the accuracy of the disease? Do you expect it is acute or subacute? This one occur in over 4 days, kan?
Uh,
The lymph nodes occur for, I think started
4 days
within
infection.
1 day, kan? Fever 4 days, kan? You mentioned, kan? So it's
Fever,
quite
no.
acute lah. So this is quite acute. Okay, usually lymphoma is more chronic lah. The cause is subacute to chronic.
Yes.
Most time is subacute lah. Okay, before you start to notice the lung. Okay, okay, what else? What other differential you've mentioned just now?
Acute leukemia.
Acute leukemia. Okay. Oh, by the way, what are what history that actually against lymphoma in this stuff?
There is no history of malignancy run in the family.
Okay, actually most lymphoma are not genetically inherited or something. Usually they don't have family history. Lagi? Besides?
The history or
Yeah, in the history, what against lymphoma? Or malignancy of sort lah. Dia tak ada loss rate kan? Dia tak ada constituent symptoms kan? Usually lymphoma, they put all these constituent symptoms lah. Such as night sweat, lost weight, okay, anemic symptoms. Okay lah. Okay, your other differential is leukemia. Lagi-lagi, what is your other differential?
post-streptococcal glomerulonephritis.
What makes you think so?
Because there is fever, sore throat. Sore throat may be because of the streptococcal infection. There is lymphadenopathy and also bilateral exudative tonsil in examination. However, for the points against, there is no hematuria that suggests the glomerulonephritis.
Okay, so AGN kan, post-strep AGN, is it common for post-strep AGN present with fever?
Not really common.
Actually, what is the pathophysiology of post-strep AGN?
After the infection, there is antibody complex.
Yes, so the antigen antibody complex. What type of hypersensitivity reaction?
Sorry.
What type of type berapa hypersensitivity reaction post-strep AGN? You know, you've got 5 types kan? Now you've got 5 types lah. In textbook memang ada 4 types, but nowadays we've got 5 types. Kan? Type 1, type 2, type 3, type 4. No, actually type 5 lah. Hypersensitivity reaction. So kalau post-strep AGN is type berapa? So because it's important tau, you have to understand because post-strep AGN is a hypersensitivity punya issue. It's an immunological disorder rather than infectious. Okay, so type 3 kan? It's type 3. Okay, it's against autoantibody against glomerular basement membrane. So basically, it is an immunological disorder triggered by infection. So it occurs only usually after resolution of infection. So after 2 weeks minimum. Okay, once you develop IgG, then only you can start to have all this immunological disorder lah. IgG start to develop between 7 to 10 days of infection kan, post-infection. So you won't get fever lah with post-strep infection, post-strep AGN. Okay. However, you can have infection lah, strep infection, you can present like this. Okay, contoh macam strep infection kan, strep pharyngitis, strep tonsillitis ke ataupun scarlet fever, benda macam ni lah. Okay, so rather than post-strep AGN, you should mention strep infection. Okay, rather than AGN. Okay, that's good. Okay, so what are the things? If patient presented with neck swelling, kan, similar cases like this presented with neck swelling, what is your worry? What is your worry? What history, very important history you should ask that you miss? This is very important history that you should ask anyone with neck mass. Because rather than focusing, because when you take history, rather than you focus on reaching to the diagnosis, you have to also assess the impact of the disease, the complication that might arise, and also the consequence of the disease itself. So what sort of history you have to ask anyone with neck swelling?
Thyroid?
Thyroid. Okay, you can ask about thyroid. So you can ask lah symptoms of thyroid, but usually because this neck swelling is quite obvious kan, dia kata dekat rather than anterior neck, dia memang sebut dekat angle of mouth, dekat jaw kan, jaw dekat side kan dia tu. So but you can kalau you tak nampak patient, then you can ask lah these questions. Thyroid. But again, 8-year-old thyroid is not common lah, especially boy kan, dia boy kan. Especially boy is not that common. What other history you have to ask? Kalau you someone present, for example, you are a consultant or you are an NO ke dekat ward, and then suddenly you nampak the new case datang, the houseman plug the case, then what are the questions you have to ask the houseman? Houseman already plug the case, what are the most important thing you have to ask the houseman? Okay, it's quite complicated lah. Basically, as a doctor, the most important thing is you have to make sure the patient is safe. Okay, by asking the most important questions that might ask about complication that might arise, life-threatening complication lah that might arise from the problems kan. So kalau you ada neck mass, what do you expect the complication? Yang life-threatening yang you kena act urgently. Kalau ada neck mass.
Dyspnea?
Dyspnea. Okay lah. So this airway obstruction. Airway obstruction. Okay. So what do you have to ask to assess airway obstruction? Apa question yang you kena tanya?
Any difficulty in swallowing?
Okay, good. Difficulty swallowing. Okay. Usually difficulty swallowing is not because of airway obstruction. It's actually because of laryngeal, recurrent laryngeal nerve compression lah usually. Tapi the obstruction itself can actually press on the esophagus, can affect your swallowing. Okay, good. You have to ask about swallowing difficulties. Besides that, more important.
Noisy breathing, stridor.
Stridor kan. You can tanya dia ada snoring ke waktu tidur. Obstructive symptoms lah. You can boleh tanya harshness of the voice. Because patient kalau dah present dengan harshness of the voice, you know that it's already pressing on recurrent laryngeal nerve kan. And it is actually recurrent laryngeal nerve is supplying your vocal cord. So kalau dah ada harshness of voice, definitely you akan ada airway problems lah. So these are the questions you kena tanya and you kena present. And when you examine the child, you kena look for all these signs, such as apa yang you kena mention in your examination. Kalau patient yang ada neck mass, noisy breathing lah, you kena sebut dalam your examination. You kena sebut there's no noisy breathing, there's no stridor. Besides that, apa lagi yang boleh berlaku kalau you ada mass dekat neck? What are the things yang your complication yang boleh jadi?
Hoarseness of voice.
Okay, hoarseness of voice. Okay, compression on the recurrent laryngeal nerve, compression on the airway. Lagi apa lagi yang dia boleh compress? Neck mass. Neck mass is very important It's a nerve threatening.
Nerve?
Okay, nerve. Nerve yang kita concern is recurrent laryngeal nerve lah. Again, and also phrenic nerve. Okay, phrenic nerve you tak nampak, tapi kalau patient dyspnea, because of phrenic nerve compression, you buat X-ray, you akan nampak semi paralysis lah of the diaphragm. Tapi besides that, apa lagi yang dia boleh compress? Just imagine lah, you ada mass dekat neck kan, dekat neck.
Blood vessels?
Yes, what vessel? Especially
Jugular vein?
dia punya main vein lah, jugular vein, dia punya superior vena cava lah. The main is superior vena cava. Carotid boleh, tapi artery ni is quite deep. Usually kalau once the compress artery tu macam very bad lah. Tapi the main is superior vena cava. So kalau dia compress superior vena cava, what sign we can see at the face? I'm not sure you dah belajar tak ni, tapi it's important lah. Okay, you pernah dengar pemberton sign tak? Pemberton sign. Oh, environmental science.
Pernah. We ask the teacher to about the end.
Okay, yang angkat tangan kan? Dia akan nampak engagement of the vessel kan?
Lesson,
So
yes.
bila you punya examination, you kena mention this. Okay, there's no evidence of environmental science was negative. Okay, there's no visible vein, superficial veins on the face, on the forehead. But this is very important because compression of the SVT is a medical emergency. Okay, so do compression of the airway. Okay, because if you compress the knee, you can lead to thrombosis kan, and then later on you boleh je macam-macam lah. Okay, so that has to be mentioned in your clinical examination. Otherwise, okay, there's satu. Kalau you ada, now you are convinced that this is a lymph nodes kan. Okay, what else you have to examine? You ada lymph node, lymphadenopathy dekat neck area. So what structure supply that lymph nodes? You ada your throat, you ada your tonsil dengan pharynx. What else you got? That supply the nodes around your neck.
Lung.
Lung tak supply. Lung tu dia punya intrathoracic lymph nodes. Tu ada X-ray boleh nampak. Your ear kan, your ear, your oral cavity. So you kena mention, benar 8 tahun, definitely gigi dia memang teruk, ada banyak caries. So you kena look at the gum, look at the teeth. So you kena mention this. Okay, oral hygiene dia macam mana, teething dia banyak caries ke, and then otoscope kena buat otoscope mesti kena buat. As far as you know, patient memang ada middle ear infection, which is can come together with the straps lah. The most common middle ear infection is straps. So straps, pharyngitis come together with otitis media ke, who knows. So you can check do otoscope and also check the oral cavity lah. Okay, otherwise, so what do you guys think about the presentation? Haris, what do you think about the Aisyah punya presentation?
I think it's okay lah tu. But
I have a question with regard to the presentation. When the parents said that there's a mass in any part of the body, and then they explain in terms yang macam kita buat clinical examination kan, height inconsistency and so on and so forth. Do we need to put it in the history, or nanti masa kita just mention dalam history there's a mass, and then masa clinical examination baru kita in detail bagi tahu finding?
Both in the history you have to describe, because usually you have to ask directed questions lah in order to get description of something kan, especially of the lung lah. You need a short, close and direct question to the mothers, to the parents. So you can tanya, is it tender kan, on palpable, is it tender when you touch, is it warm? You will tanya that, and they should offer the information lah. And if they offer the information, then you should present.
Okay.
Examination also you have to examine again for all this, because ideally 60 to 80% of diagnosis should come from your history, and supported the rest 20% supported by your clinical examination, and another like 10-20% based on investigation lah. So you kena imagine you are dekat district kan yang tak ada investigation, then you have to rely on your history lah, history skill. Okay. Otherwise, that's very good presentation. I like the flow of your presentation, but this is a cheating lah kan. So this is based on your case write up kan. Definitely you don't have that much time lah in exam to prepare. But if you can practice this flow, I mean this the way you present this time, I mean if you can repeat this in your long case, this absolutely Very good lah, very good. Okay, the flow is there. You managed to actually present, I mean, get most of the presenting complaint, history of presenting complaint. However, some as I mentioned, some important, there are some important information are missing lah, were missing from your presentation. But it's okay, that's very good. And then what's good is you did mention how the illness actually, how each of the symptoms affect the life. For example, you mentioned the neck mass affect the movement kan. You cakap doesn't affect the neck movement, patient still can turn. And then it's good if you can mention patient did not skip schooling throughout the illness, so kita tahu lah the severity, so we can estimate the severity. And then mana tadi? The description of your periorbital swelling is very good. Okay, you even mentioned the swelling does not affected by time kan, doesn't worse in morning or doesn't become worse in the afternoon, because it helps with the diagnosis kan. And then you did mention about there's no edema elsewhere, so if you've got edema then you know this is something more systemic kan, macam nephrotic syndrome ke macam tu lah. And I think that's all I've got. Any other comment ke from the rest? Tadi
Tak ada tu.
Okay, good. Okay, Aisyah ada soalan? Okay. So kita boleh move to the next one. Siapa next?
Me.
Siapa me ni? Sekejap. Siapa?
Syafatin.
Syafati.
Okay, Syafatin. Sekejap boleh tak bagi I dalam 2 minutes? Sekejap. Lagi beli something.
Boleh.
Sekejap Okay, Syafatin boleh start?
Okay. Assalamualaikum. I am Shafatin and I would like to present about R, an 8-month-old male infant presented to the emergency department of HTAA with rapid breathing which lasted for 6 hours. So the history was taken from the patient's biological mother on the same day of admission. The patient was relatively well until 4 days prior to admission as he developed fever, which was sudden in onset and was not associated with chills and rigor. The documented temperature at home was 37.5 degrees Celsius. The fever subsided with paracetamol but only temporarily, and then it was persisted for 4 days until the day of admission. So the onset of fever was also associated with runny nose, which also lasted for 4 days. The nasal discharge was clear in appearance. 2 days prior to admission, the patient started to cough. The cough was non-productive and was described as barking cough. There was no history of sick contact, recent travelling, or going to crowded places. His mother noticed that he babbled less since then, but she was not sure about any hoarseness of voice. The cough became persistent and caused him to experience 3 episodes of post-tussive vomiting 1 day prior to admission. It happened post-feeding, and the vomitus was minimal in amount and contained milk only. Since then, his oral intake also became poor. There were also 3 episodes of loose stools 1 day prior to admission. The stools were poorly formed but not entirely watery. Otherwise, there was no overflowing diapers. The stools were yellowish in color but no mucus or blood present. There was no history of eating outside food and no one in the same household had the same symptoms. There was also no recent change in his diet. Plus, the patient did not come from a dengue-prone area. There was also no recent water activity. 6 hours prior to admission, the patient started to breathe rapidly as he was playing by himself while being observed by his mother. Otherwise, his mother denied any noisy breathing. His mother did not notice if the patient put anything inside his mouth. There was also no choking episode. There was no excessive drooling, chest indrawing at the supraclavicular or subcostal area during the rapid breathing. There was also no bluish discoloration of the lips or presence of cold extremities. The patient had history of hospital admission once with the same presentation and he was hospitalized for 4 days. According to his mother, the patient received nebulized drug in which she was not sure what drug it was, syrup paracetamol and antibiotics during the admission. Upon further questioning, the patient was brought to the general practitioner on day 1 of fever. He was prescribed with syrup paracetamol. No antibiotic was given. On the day of admission, he was brought to the GP first and received nebulized drug once there. He was then referred to HTAA as the GP told the mother that his respiratory rate was fast and he also had chest recession. At the ED of HTAA, he received nebulized drug twice before being admitted to the pediatric ward. There was also very mild resolving eczema on his cheeks. Otherwise, there was no other skin changes. There was also no loss of weight. There was no issue with feeding, such as interrupted or prolonged feeding or even breathlessness during feeding. No cyanosis or pedioedema. There was no noisy breathing, cyanosis or hemoptysis. There was no constipation, hematemesis, hematochezia or melena. There was no hematuria, frequency or proteurine. There was no abnormal movement, paralysis or seizure. There was no bleeding tendency, such as easy bruising, epistaxis or gum bleeding. There was no ear discharge or lipodynopathy. The patient had underlying glucose 6 phosphate dehydrogenase deficiency, which was diagnosed right after he was born. He had a strong family history of G6PD deficiency from his paternal side. He had never been admitted to the hospital in regards to his G6PD deficiency. He also had underlying hypothyroidism, which was also diagnosed soon after being born. His mother had hyperthyroidism and was on treatment during the pregnancy. Currently, the patient was on thyroxine. The patient also suffered from eczema since he was 6 months old. At the moment, he was not using any topical creams for the eczema. Other than established triggers of hemolysis in G6PD deficiency, he had no known drugs or food allergy. His mother denied giving him any other supplemental medication. There was no known past surgical history. Antenatally, the mother suffered from hypothyroidism and anemia during pregnancy. Otherwise, the mother denied any other medical problem during pregnancy, including GDM and pregnancy-induced hypertension. Intranatally, the patient was born preterm at 36 weeks of gestation via spontaneous vaginal delivery due to early contraction. His birth weight was 2.4 kilogram with length of 48 centimeter. There was no complication during the delivery. Postnatally, the patient was admitted to the NICU for 21 days and required continuous positive airway pressure during the first week there. He also had jaundice, which was confined to the head and neck only. He received phototherapy for 3 days. The patient was fed via nasogastric tube soon after he was born. He started to be breastfed on day 16 of life. He was breastfed around every 2 hours and on demand. At 4 months old, he was introduced to formula milk and returned to full-time breastfeeding. Soon after, he started weaning with purees and eventually with other food. That at 6 months old, he started weaning with purees and eventually with other food. Now at 8 months old, he had already been eating porridge, blended chicken and fish. He was usually fed 3 times daily and still being breastfed. For gross motor, the patient could sit without support, put himself to stand and can stand with support. He could also roll over from supine to prone position. For fine motor, the patient showed a palmar grasp of cube and could transfer the cube from one hand to another. He also looked in the correct direction for fallen toys. For speech and or language, the patient responded to his name and turned his head towards sound. He also babbled in single syllable. For social behavior, the patient stretched his arm out when wanted to be carried. He understood when someone said no. He did not seem to be anxious around strangers. He could also wave bye-bye. His immunization was up to schedule according to his age. So far, he had never experienced fever or allergic reaction following vaccination. Otherwise, he did not take any other additional vaccines. His father was 30 years old with underlying G6PD deficiency and also allergic rhinitis. His mother was also 30 years old with underlying hyperthyroidism since 2016. She also had allergic rhinitis. The marriage between the parents was not consanguineous. The patient had a healthy 6-year-old sister. His mother had a miscarriage before conceiving him. It happened as the mother received a higher dose of ticarbimazole for her hypothyroidism. The patient's paternal grandfather and paternal uncle also had G6PD deficiency. Otherwise, there was no family history of asthma or eczema in the family. There was also no malignancy or autoimmune disease in the family. The patient, along with his parent and sister, lived in Kuantan. The house was equipped with good water supply and electricity. His father worked as a banker with an average monthly salary of 3,000 ringgit. He was an active smoker since the age of 12. He smoked 10 cigarettes per day, but never inside the house or in the presence of the family members. His mother is a full-time housewife. For physical examination, the patient was examined after he had received budesonide, and salbutamol. On general inspection, the patient was alert and active, not toxic looking, was sitting comfortably on his mother's lap while playing with his toys, not in respiratory distress, as there was no nasal flaring, expiratory grunting, or chest recession observed. The respiratory rate was 30 breaths per minute. The patient occasionally produced barking cough. There was a branula attached on his right dorsal hand with no active infusion. His physical size seemed appropriate for his age, otherwise there was no dysmorphic features. On palpable examination, the pumps were warm, the capillary refill time was less than 2 seconds, there was no peripheral cyanosis, finger clubbing, leukonychia, koilonychia or palmar erythema. Splinter, hemorrhage, granulation and osseous node were also absent. BCG scar was seen on his left deltoid area. On head and neck examination, there was mild conjunctival pallor. There was no scleral jaundice, no sunken eyes or coated tongue, no injected pharynx or enlarged tonsils, and no central cyanosis observed. There was no lymphadenopathy. The trachea was centrally located. The jugular venous pressure could not be assessed. On late examination, there was no pedal edema. For his vital signs, his blood pressure was hypotensive, 90 systolic with and 50 diastolic millimeter mercury. His pulse rate was 150 beats per minute, regular rhythm and good volume. His respiratory rate 30 breaths per minute. His body temperature was 37.9, which is febrile. And his SpO2 is 99% under nasal prong. For his anthropometric measurement, he weighed 8 kilogram. His height is 67 centimeter, making his BMI 17.8, which is normal. His head circumference is 44 centimeter. For respiratory examination, on inspection, there was no chest deformity, scars or dilated veins. The chest moved symmetrically with respiration. On percussion, both anterior and posterior sides were resonant at all zones. On auscultation, both anterior and posterior sides have vesicular breath sound and equal air entry with no added sound. The chest expansion, tactile and vocal parameters could not be assessed in this patient. For cardiovascular examination, the radial pulse could not be appreciated. The other peripheral pulses were present. The radial and radiofemoral delays were not assessed. There was no collapsing pulse. On inspection of the precordium, there was no visible pulsation, skulls or dilated veins. On palpation, the apex beat was not displaced, situated at the fourth intercostal space on the left mid-clavicular line. There was no trill or parasternal heave. On auscultation, S1 and S2 were heard with no murmur and no added sound. In abdominal examination, on inspection, the abdomen was not distended and moved with respiration. The umbilicus was centrally located and was inverted. There was no scar, visible peristalsis or abnormal pulsation observed. On palpation, the abdomen was soft and non-tender. The liver was palpable, 1 centimeter below the right costal margin. The liver span was 5 centimeter. The spleen was not palpable. Both kidneys were not ballotable. On percussion, shifting dullness was negative. The throat space was negative. On auscultation, normal bowel sound was heard for 12 times in a minute. In neurological examination, the pediatric Glasgow Coma scale obtained was 15/15. There was no abnormal posture, muscle wasting, or fasciculation. Both upper limbs and lower limbs have normal tone, power at least 4/5, and reflex 2+. Babinski's sign was outgoing. The proprioception, sensation, cranial nerves, and cerebellar signs were not assessed. So, to summarize, R, 8-month-old male infant being referred to the ED of HTAA, presented with rapid breathing, non-productive barking cough, post-tussive vomiting, low-grade fever, coryza, and chest recession. He also had loose stools. On his arrival at the ED, he was tachypneic and had chest recession. His physical examination post-budesonide and salbutamol showed no respiratory distress with respiratory rate of 30 breaths per minute.
Dah ke? Habis?
Dah.
Oh, tu lah. Dengar pun penat lah. Anyway, okay. So what's your differential?
For provisional. For my provisional diagnosis, I think it is viral throat because this patient is presented with rapid breathing, low-grade fever, runny nose, non-productive barking cough, chest recession, and also post-tussive vomiting. However, there is no stridor, no hoarseness of voice observed, and there is loose stools. For my differential diagnosis, it could be foreign body aspiration because this patient presented with rapid breathing, coughing, vomiting, reduced oral intake, and also febrile. But there is no foreign object insertion into the oral cavity observed. There is no choking episode, no wheezing or stridor, and also no hoarseness of voice. My second differential diagnosis is a spasmodic croup uh, because of rapid breathing of the symptoms. However, the patient have no stridor, no hoarseness of voice, has low-grade fever and also runny nose. My third differential diagnosis is acute epiglottis due to presentation of rapid breathing, chest recession, and also reduced oral intake. However, acute epiglottitis is not common in infants. Um, there is also no drooling, no stridor, not toxic looking, no currently tachypnic. Because of there is barking cough. Um, my fourth differential diagnosis is pseudomembranous croup. However, presentation that against this differential diagnosis is that this patient have low-grade fever, it's not toxic looking, no rapid deterioration, no copious purulent secretion, no stridor, and also pseudomembranous croup also not common in infants. For my fifth differential diagnosis is viral pneumonia because of presentation of rapid breathing, cough, low-grade fever, runny nose, post-tussive vomiting, also reduced oral intake. However, there is no dullness on percussion, no crepitation on auscultation, and there is also no history of seat contact. Uh, I think that's all for my
Okay,
professional.
so let me clarify. So the main presenting complaint is actually rapid breathing kan?
Yes.
Rather than noisy breathing or harshness of
Mm.
hoarseness of hoarseness of voice.
Voice.
Hmm. So you don't have any besides viral pneumonia, you don't have any other like respiratory punya ni respiratory punya differential. I mean lower respiratory.
Maybe acute bronchiolitis.
Okay, so I think you should put acute bronchiolitis now.
Mm.
No need. Or other wheezing. Is this the first episode of wheezing? The first episode of rapid breathing?
No, because previously he had he had hospitalization due to same reason.
Same reason kan?
Mm.
So chances are possible dia ni ada some wheezing lah, episodic wheeze. Most likely the multi trigger or viral induced kan.
Mm.
Itulah group at
Oh.
age 8 month old group slightly rare lah. Usually group is slightly older. So 3 years old macam tu lah. Or 1 year old. 8 month old ni macam slightly young, but it's possible. And then I think you should put all the first few diagnosis lower, especially
Okay.
pseudotitis, pseudomembranous group. Because these are very rare nowadays, and usually they are very septic. They are very septic. Because your examination is actually normal kan semua.
Yes.
The whole your examination is normal, so you can actually put this down the list lah. Better
Okay.
bronchiolitis semua tu higher up. Okay, so you've mentioned about croup. So what is croup?
Croup is clinical syndrome that Kejap. Croup is a
What the other name of croup? Croup is a lay term. The the medical term is
laryngotracheolitis.
Bronchitis.
Bronchitis.
bronchitis kan?
Tracheobronchitis.
Tracheolaryngobronchitis kan? ALP kan? Okay, so
Yes.
it's an inflammation lah. It's an inflammation. As the name implies, it's inflammation caused by usually
Caused
viral
by
infection lah.
viral
Kan?
infection.
What sort of viral yang selalu cause croup?
Usually mainly human parainfluenza virus,
Influenza lagi?
respiratory syncytial virus, influenza virus, adenovirus,
Biasa
enterovirus.
influenza dengan RSV dia cost lower lah, lower. Dia benda yang apa ni macam biasa influenza the most common. So ada lah yang pelik-pelik sikit, novovirus lah, benda-benda pelik-pelik lah. Enterovirus yang pelik lah. Just mention any virus, dia betul lah. Okay, and then so what is the treatment for group? How do you stage, how do you classify groups?
We use a Wegener's clinical assessment of group. So it for severity of the group. So it has three classification: mild, moderate, and also severe. For mild, for group with mild severity, the clinical findings is stridor with excitement or at rest. However, there is no respiratory distress. For moderate severity of group, there is stridor at rest and also intercostal or suprasternal or subcostal recession. And for severe severity of severe group, there is stridor at rest with marked recession, reduced air entry, and also altered level of consciousness.
Okay, so that's why when you have to know this, so that in your history you have to ask this. Okay, ask. You mentioned the mother said ada hoarseness of voice kan? So you can tanya, is it at rest? Was it when patient laugh or when patient cry? So you kena I mean go detail on this lah. So you tahu dia, because from history you should already get your diagnosis and you should be able to stage the severity just by the history. Okay, and then how do you manage? Any guess? Kalau tak tahu lah, any guess? Kita tahu kot senang je manage group ni.
Sekejap benda.
Tak payah hospital admission pun, bro.
Steroid.
Steroid kan? Simple lah.
Steroid and
because it's inflammatory kan condition, then usually the treatment is anti-inflammatory lah. Kalau you tak tahu, just put anti-inflammatory. So sebut steroid. Okay. Any sort of steroid will do lah, but usually we give nebulized budesonide. Kalau tak boleh, then we give adrenaline. Okay, to prevent edema lah. The main treatment is actually what happen in group if they've got edema lah. Edema due to inflammation, they've got edema of the vocal cord and above supraglottis, usually supraglottis area. Okay, so what sort of stridor would you have in group? Expiratory ke mix ke macam mana? Even though we know the definition of stridor is inspiratory kan, but you can have expiratory stridor. You can, because it depends on the level of the obstruction. Okay, so in group the level of obstruction is actually supraglottis, so you get inspiratory stridor. Okay, in epiglottitis, however, because it's actually at the glottis level, you can get both. Okay, even lower down you can get expiratory lah. Lower down macam bronchitis lah, severe bronchitis, bacterial bronchitis kan, for example, you can get inspiratory stridor. Okay, so what are the noisy breathing that you know of?
stridor.
Sorry. Okay, you have stridor kan? Lagi you have stato. You ada stato. Stato is higher up lah, dekat nasal. Dia very much higher up of your respiratory tract. So usually nasal. Stato ni dengkur lah. Okay, dengkur is stato, and then you've got stridor, and then you've got wheezing. Okay, this is the three lah. Ni you've got gurgling sound lah. Gurgling sound ni usually gurgling lah, just gurgling. So you've got about 4 lah for noisy breathing. And then okay, so I've got a few questions about your history. You mentioned about the child got G6PD kan? By the way, how many siblings did you got?
He has a sister, 6 years old.
6-year-old sister. Is she G6PD deficient?
No.
Okay,
It's not stated.
what sort of inheritance G6PD has?
Autosomal dominant?
Any takers? Anyone?
X-linked recessive.
It's
X-linked. X-linked recessive.
So what do you expect if a boy has this deficient? What do you expect? Where the boys, from who does the boys get the G6PD gene?
From the mother.
From the mother kan? But this one, the whole the father is very weird lah. The family history is very weird because the father got G6PD deficient. The paternal grandfather got G6PD deficient. That is very weird. Okay, you won't, because G6PD dia is all G6PD are autosomal recessive. Okay, dia tak ada variable genetic inheritance. Ada lah, there are some like small type, very minute rare type of G6PD yang caused by autosomal recessive, tapi mainly they are caused by X recessive. So you don't expect the father the disease run in boys. The disease should run the disease should run in boys, tapi it should not
direct
from each generation, male generation. Dia tak macam tu. Dia pelik, father punya datuk ada and then father ada. This is very weird.
Uncle ada.
Uncle. So this is very weird tau. Kalau uncle dengan ayah dia ada, that's possible. Okay. Tapi the grandfather shouldn't have, unless kalau family ni yang pelik, dia kahwin sama-sama G6PD je. Faham tak? Maksud dia, datuk dia dah tahu dia ada G6PD, so dia cari perempuan yang ada G6PD carrier supaya semua anak dia dapat G6PD. And then anak dia ada G6PD pun kahwin dengan perempuan yang ada carrier G6PD supaya anak dia semua dapat G6PD, which is very rare lah. Because female G6PD is very rare. Usually this kind of family, dia akan ada, the whole family members ada G6PD, both male and female. So I think you can clarify the history lah. And then mother dia ada hyperthyroid on carbimazole.
Yes.
Actually I'm not sure about carbimazole in pregnancy. Because I thought it's PTU. I think PTU mungkin buat PTU. Prophythyroidism maybe tak boleh. I think carbimazole yang tak boleh. If I know basically, maybe you should check. But in pregnancy, carbimazole is contraindicated lah in pregnancy. Usually those on carbimazole kita akan change to PTU during tapi you better check lah, you better check. And
bukan PTU tu during the first pregnancy je, tapi carbimazole tu during second and third.
Mungkin kot. You check lah, you check and then tell me. Cuba check, Lisa cuba check tu.
Okay, saya check.
Lepas tu beritahu saya. And then postnatally you mentioned the child was admitted to an ICU for 21 days kan? Why
Stated here that he required CPAP during the first week there.
Dia require CPAP tapi kenapa?
I'm not sure.
Maybe it's good to clarify lah. Maybe sama dia infectious ke, infection punya program ataupun dia ada something else macam pulmonary hypertension ke, myocardial aspiration ke. To have that information. Tapi tak intubated lah.
No.
Okay, there's satu development kan. Okay, when you ask development, first you should present what the patient can do. Okay. Okay, then you can go up one milestone. You can you can, and then you can present other milestone for the age, faham tak? Because this child dia dah boleh sit upright kan, sit unsupported. Then I expect you to present about crawling. Tapi you didn't mention about crawl, but rather you mention about rollover. Because rollover ni 4 months tau. 4 months baby dah boleh rollover. So crawling comes quite close. Actually crawling come out before usually come together lah, ataupun before sit unsupported. So I expect you akan mention about the crawl, tapi you tak mention. I know this is very tiny, but development should tally to the age lah. So the aim of development history is actually to determine whether this is age appropriate development ataupun age inappropriate. And then it's good you mention about the allergy. Apa lagi? Tu je kot. Oh, ada satu yang kelakar sikit. Full time housewife. I tak pernah dengar lah part time housewife. So, tu yang benda yang tiny things lah. Otherwise your present again the flow is okay. Cuma one comment lah. There's too much negative yang unrelated. I'm not sure kenapa you macam fokus sangat on bleeding tendency. Sebab from history that doesn't sound like patient ada anemia kan? Ke ada?
Because D3 deficiency kan, so she could have hemolytic anemia.
So you're thinking that because in your differential pun you tak ada mention hemolysis, because are you thinking that the respiratory distress are due to anemia ke? Is that what you're thinking?
Maybe.
Because I mean in your presentation, in your clerking and in your examination, even in your differential you tak sebut pun pasal hemolysis as the cause of shortness of breath kan, rapid breathing. Tapi in your history banyak sangat negatif. I mean it might be important negative on hemolysis and also bleeding blood loss. Tu cepat.
Okay.
Ada komen? Anyone?
I have no comment, Doctor.
Okay, any questions? To Syafatin? Syafataini kan? Syafataini. YPB. Kan, tu maksudnya kan? Syafataini. Syafatin.
Betul.
Tapi dulu Ustaz saya pernah, Ustazah ke Ustaz? Sekejap. Ustaz pernah cakap maksud dia dekat apa? Maksud dia dua kebijaksanaan.
Oh, okay. Mungkin apa? Saya dulu ingat kau belajar tajwid tu, belajar makhraj huruf, Asyaftaini salah satu dia makhraj huruf tu. Tempat keluar huruf. Berapa kalau Asyaftaini macam
Bawau.
Bawau.
Mim.
Mim. Bagus. Okay, Anissa dah check dah? Malas nak baca.
Dah.
Apa dia kata?
Betul lah, dia kata PTU tu boleh pakai waktu first pregnancy sebab dia high protein bound so can cross the placenta.
Maksudnya apa? PTU can cross placenta?
Tak, kenapa PTU guna waktu first pregnancy?
First trimester?
First trimester.
Kenapa?
Sebab dia high protein bound cannot cross the placenta.
Oh, okay.
Yang carbimazole pula during second and third trimester tu sebab dia less hepatotoxicity.
Dia less apa?
Hepatotoxicity.
Habis maksud less hepatotoxicity daripada PTU. So dia guna waktu second and third trimester.
Yes.
Okay, first trimester pakai PTU.
Yes.
Okay, good. Okay, bagus. Okay, so new things learn. Okay, apa lagi? Lagi satu, yes, it's very important in your physical examination. Is it routine untuk you check for all the IE punya sign ke? Especially in baby, it's very rare kot IE.
No.
kan, unless kalau baby ni dia memang ada underlying congenital heart defect lah, macam ada VSD lah, especially VSD atau pulmonary stenosis, left side punya problem, macam VSD, PDA. Kalau tak, don't routinely mention lah ni, because it doesn't to be honest, it sound like macam you just letak je semua benda. Doesn't show that you're thinking lah, doesn't show that you're thinking. Splinter hemorrhage tu memang susah pun nak nampak kat baby. I never seen any baby with splinter hemorrhage. Even any child with splinter hemorrhage pun very difficult. Okay. Unless kalau dia memang ada congenital heart disease, especially septal defect, then you should mention this. General lesion tu lagi lah. Okay lah. Cuba ada soalan?
Tak ada doktor.
Okay, good. So saya nak bagi markah. Boleh tanya, you guys ni saya punya ni ke? Saya punya
Menti.
Menti ke?
menti semua?
Bukan.
Bukan kan? Siapa yang saya menti?
Dia kalau menti dia akan jadi dapat extra mark ke doktor?
Tak. Kalau menti saya nak kena examine you punya apa tu? Case apa you sebut tadi? Case
Write up.
Kalau menti saya nak kena examine you punya case write up. So since you present based on your case write up, saya bagi tu sama makan case write up. Saya malas nak baca dah. Siapa menti saya kat sini? Aisyah bukan eh?
Bukan.
Kita orang menti Dr. Sack.
Satu group menti Dr. Sai.
So ada tu saya baca you punya case write up. So untuk you punya long case, Aisyah, I like your presentation. The flow is very good. I bagi you 9 lah, saya bagi you 9. Syafatin, the flow is there. Tapi because of banyak sangat negatif macam okay lah, I bagi you actually cheating lah ni sebab ni based on new case write up kan. Dapat Aisyah kurang sikit lah, I bagi you 8.5 je. 8.5, Syafatin I bagi you 8. Okay? Okay, good. Nanti you beritahu lah Farah ke Hidayah dia punya marks untuk long case. 8.5 dengan 8. Okay, that's all lah. Kita tangguhkan tasbih ke Farah dan sepatu mas. Okay, assalamualaikum warahmatullahi wabarakatuh.
Thank you, doktor.
Okay.
Thank you, doktor.
Thank you, doktor.
Thank you, doktor.